Anatomy and Physiology with Pathophysiology. Welcome! Are you excited for a fun learning session? Yes? Yes, our topic for today is all about respiratory system. We often hear the phrase, I cannot live without you, in some romantic movies. But in fact, we cannot live without breathing. Am I right? Breathing is very essential to our body and it is one of the processes occur in the respiratory system. The major function of respiratory system is to supply the body with oxygen and dispose carbon dioxide out from our bodies. This system includes the nose, nasal cavity and perineal sinuses, the pharynx, larynx, trachea, the bronchi and their smaller branches, and the lungs, which contain tiny air sacs called alveoli. The functions of the respiratory system are gas exchanges between the blood and external environment, which occurs in the alveoli of the lungs. It includes all the respiratory passages, which provide fairly rigid conduits for air to reach gas exchange sites, and it also purify, humidify, and warm incoming air so that the air that reaches the lungs has fewer irritants such as dust and bacteria than when it entered the body. The nose. The nose is the only externally visible part of the respiratory system. We have different varieties of nose, the matangos, pango, and medium. Char. The nose provides an airway for respiration. It moistens and warms entering air. It filters and cleanses inspired air. It serves as a resonating chamber for speech and houses olfactory receptors. Olfactory receptor. It is our sense of smell. We can smell because of this olfactory receptor. So here is the external nose. The nostrils is located right here. The olfactory nerves is this kanang may ugat-ugat dyan. Yan ang olfactory nerves. And you can also see the olfactory bulb and the olfactory tract. Anatomy of the nasal cavity. Olfactory receptors are located in the mucosa on the superior surface. Yes, so I already showed you where the olfactory nerves are located as well as the olfactory bulb and the olfactory tract. The rest of the cavity is lined with respiratory mucosa that moisten air, trap incoming foreign particles. Mucosa, by the way, is a moist tissue that lines certain areas of our body. Its primary function is absorption and secretion of particular substances. Lateral walls have projections called conchae. It increases surface area, increases air turbulence within the nasal cavity. The nasal cavity is separated from the oral cavity by the palate. The two palates are the hard palate and the soft palate. The hard palate is supported by a bone and it is located at the anterior part of our face, and the soft palate is unsupported with bones and it is composed of muscle which is on the posterior part of our face. Paranasal sinuses. The nasal cavity is surrounded by cavities called sinuses. It is located in the frontal bone, sphenoid bone, ethmoid bone, and maxillary bone. Yes, we already have a background about sinuses because it has been discussed in our previous discussion on the skeletal system. So this is the hard palate, which is just right above our gums, and the soft palate at the posterior part of our face. So this is the perineal sinuses. So we have the frontal sinus, ethmoidal sinus, sphenoidal sinus, and the maxillary sinus. The functions of the sinuses are, it lightens the skull, which it reduces the weight of our skulls. It acts as a resonance chambers for speech, and it produces mucus that drains into the nasal cavity.
And now moving on to the next organ in the respiratory system that we are about to discuss, we have the pharynx or the throat. The pharynx is a muscular passage from the nasal cavity up to the larynx. There are three regions of the pharynx, and these are the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx is a superior region behind the nasal cavity. The oropharynx, on the other hand, is the middle region behind the mouth. And the laryngopharynx is the inferior region attached to the larynx. Both the oropharynx and laryngopharynx are common passageways for air and food. Now, the pharynx is part of both the digestive and respiratory system. As a component of the upper respiratory tract, the pharynx is part of the conducting zone for air into the lungs. Therefore, one of its primary functions is to warm and humidify air before it reaches the lungs. Again, take note, one of the primary functions of the pharynx is to warm and humidify air before it reaches the lungs. Shown on the next slide is an illustration of where the pharynx and its three regions are located. First, we have the nasopharynx being represented by a deep red color. Then we have the oropharynx being represented by a sky blue color, and the laryngopharynx being represented by a deep blue color. Now, moving on to the structure of the pharynx. Pharyngotympanic tubes open in the nasopharynx. Tonsils of the pharynx. We have the pharyngeal tonsil or the adenoid is located in the nasopharynx. The palatine tonsils are located in the oropharynx. The lingual tonsils are also found at the base of the tongue. Now, this slide shows all the different parts that make up the upper respiratory tract. Now, moving on to the next topic, we have the larynx or the voice box. The larynx is considered as the route for air and food into proper channels. The larynx also plays a role in speech. The larynx is made up of 8 rigid hyaline cartilages and a spoon-shaped flap of elastic cartilages, or also called the epiglottis. Now, briefly, the vocal folds are folds of tissue located in the larynx that have 3 important functions: to protect the airway from choking on materials in the throat, to regulate the flow of air into our lungs, and the production of sounds used for speech. Now we have the structure of the larynx. First is the thyroid cartilage. The thyroid cartilage is the largest of the hyaline cartilages. It protrudes anteriorly. When we say anteriorly, it means upper. For example, is the Adam's apple. Next, we have the epiglottis. It protects the superior opening of the larynx. It routes food to the esophagus and air toward the trachea. When swallowing, the epiglottis rises and forms a lid over the opening of the larynx. Now we have the vocal folds or the true vocal cords. These vibrate with expelled air to create sound. So the vocal folds are the ones responsible for allowing us to speak. And next we have the glottis or the opening between the vocal cords. Now this illustration is just the same to the illustration shown before in the pharynx. So let's move on. So now moving on to the trachea. The trachea, or colloquially called as the windpipe, is a cartilaginous tube that connects the larynx to the bronchi of the lungs, allowing the passage of air, and is present in almost all air-breathing animals with lungs. The trachea is a 4-inch long tube that connects the larynx with the bronchi, as I have said earlier. Its walls are reinforced with C-shaped hyaline cartilage. It is lined with ciliated mucosa that beats continuously in the opposite direction of incoming air and expel mucus loaded with dust and other debris away from the lungs for protection. Now we have an illustration of how the trachea is made. In the center, you can see this label called the lumen of trachea. The lumen of trachea acts as a channel that traps all of the particles directed towards it by the mucosa. We can also see the different parts of the trachea that surrounds it. First is the hyaline cartilage, then we have the adventitia, then the seromucous gland in the submucosa, and the trachealis muscle.
In this slide, we will tackle the topic about main or primary bronchi. Main bronchi is formed by division of the trachea. It enters the lungs at the hilum or medial depression. Right bronchus is wider, shorter, and straighter than the left. Bronchi is subdivided into smaller and smaller branches. Here is the anterior view of the lungs' flank mediastinal structures. As you can see, we have here the trachea, or colloquially called as the windpipe. It is a cartilaginous tube that connects the larynx to the bronchi of the lungs, allowing the passage of the air. The thymus is a specialized primary lymphoid organ of the immune system. The apex of the lungs, or apex pulmonis, is rounded and extends into the root of the neck, reaching from 2.5 to 4 centimeters above the level of sternal end of the first rib. The right upper lobe of the lung is located in the right superior corner of the thoracic cavity, lateral to the trachea and esophagus. The horizontal fissure, also called as the minor fissure, is a unilateral structure in the right lung that separates the right middle lobe from the right upper lobe. The right middle lobe, or simply the middle lobe, is one of the three lobes in the right lung. It is separated from the right upper lobe above by the horizontal fissure and the right lower lobe below by the right oblique fissure, and is subdivided into two bronchopulmonary segments. The oblique fissure, which extends from the costal to the mediastinal surface of the lung, both above and below the hilum. The right inferior lobe of the lung is divided into 5 bronchopulmonary segments on the basis of the division of the right superior lobe bronchus into 5 segmental bronchi, which is the apical or superior, medial basal, anterior basal, lateral basal, posterior basal bronchopulmonary segments. Next, we have here the heart. The heart is a muscular organ which pumps blood through the blood vessels of the circulatory system. The heart lies within the pericardial cavity in the middle mediastinum. The pericardial cavity is similar in structure and function to the pleural cavity. The pericardium provides a friction-free surface for the heart to accommodate its sliding movements. The diaphragm is the primary muscle used in respiration, which is the process of breathing. This dome-shaped muscle is located just below the lungs and heart. It contracts continually as you breathe in and out. The base of the lung, or basis pulmonis, is broad, concave, and rests upon the convex surface of the diaphragm, which separates the right lung from the right lobe of the liver and the left lung from the left lobe of the liver, stomach, and the spleen. The left upper lobe is one of two lobes in the left lung. It is separated from the left lower lobe by the left oblique fissure and subdivided into 4 bronchopulmonary segments, 2 of which represents the lingula. The left inferior lobe is located below and behind the oblique fissure and also contains 5 bronchopulmonary segments. In the small box shown in the upper right, we have here the intercostal muscles, rib, parietal pleura, pleural cavity, and the visceral pleura. The intercostal muscles are several groups of muscles that run between the ribs and help form and move the chest wall. Ribs are long curved bones which form the rib cage, part of the actual skeleton. In most tetrapods, ribs surround the chest, enabling the lungs to expand and thus facilitate breathing by expanding the chest cavity. Parietal pleura is the outer membrane which is attached to the inner surface of the thoracic cavity. The pleural cavity, also known as the pleural space, is the thin fluid-filled space between the two pulmonary pleurae, or known as the visceral and parietal of each lung. The visceral pleura is the delicate membrane that covers the surface of each lung and dips into the fissures between the lobes of the lung. In this slide, we have here the transverse section through the thorax viewed from above, where lungs, pleural membranes, and major organs in the mediastinum are shown. Here in the left side, we have the vertebrae. The vertebrae are the 33 individual interlocking bones that form the spinal column. Each vertebra has three main functional components: the vertebral body for load bearing, the vertebral arc to protect the spinal cord, and transverse processes for ligament. Next is the right lung. The right lung has both more lobes and segments than the left. It is divided into three lobes: an upper, middle, and a lower lobe by two fissures, one oblique and one horizontal. Then we have the parietal pleura, visceral pleura, pleural cavity, which I just discussed earlier. The pericardium is the membrane that encloses the heart and the roots of the major heart vessels, consisting of an outer fibrous layer or fibrous pericardium and an inner double serous membrane layer or serous pericardium. The sternum or breastbone is a long flat bone located in the central part of the chest. It connects to the ribs via cartilage and forms the front of the rib cage, thus helping to protect the heart, lungs, and major blood vessels from injury. And in the right side, we have the esophagus. It is a muscular tube that connects the pharynx to the stomach, allowing swallowed food to pass into the digestive system. It passes into the posterior mediastinum from the superior mediastinum, descending posteriorly to the arc of the aorta and the heart. Next is the root of the lung. It is the collection of structures that connect the lung to the mediastinum. This includes the pulmonary arteries and veins, the primary bronchi and bronchial arteries, and the pulmonary nerve plexuses and lymphatics. The hilum is the place on the lung where these structures enter and leave the lung. The left main bronchus is longer, runs more horizontally, and is about twice as long as the right main bronchus. The left pulmonary artery, or LPA, is one of the branches of the pulmonary trunk, branching at the level of the transthoracic plane of Ludwig. It is shorter than the right pulmonary artery and represents a direct posterior continuation of the pulmonary trunk. The pulmonary veins are the veins that transfer oxygenated blood from the lungs to the heart. The largest pulmonary veins are the four main pulmonary veins, two from each lung that drain into the left atrium of the heart. The left lung is one of two lungs located in the left hemithorax on the left of the heart and mediastinum. The thoracic wall consists of a bony framework that is held together by 12 thoracic vertebrae posteriorly, which give rise to ribs that encircle the lateral and anterior thoracic cavity. The pulmonary trunk is the first and largest vessel within the pulmonary arterial tree. It passes the oxygenated blood from the heart to lungs. The mediastinum is a division of the thoracic cavity. It contains the heart, thymus gland, portions of the esophagus and trachea, and other structures. For clinical purposes, it is traditionally divided into the anterior, middle, posterior, and the superior regions. Then we have the anterior mediastinum. It is the portion of the mediastinum anterior to the pericardium and below the thoracic plane. It forms the anterior part of the inferior mediastinum and contains the thymus, lymph nodes, and may contain the portions of a retrosternal thyroid. The lungs. The lungs occupy most of the thoracic cavity. Heart occupies central portion called mediastinum. Apex is near the clavicle or superior portion. Base rests on the diaphragm or inferior portion. Each lung is divided into two lobes by fissures, the left lung with two lobes, the right lung with three lobes. The coverings of the lungs. Serosa covers the outer surface of the lungs. Pulmonary or visceral pleura covers the lung surface. Parietal pleura lines the walls of the thoracic cavity. Pleural fluid fills the area between layers of pleura to allow gliding. These two pleural layers resist being pulled apart. The bronchial or the respiratory three divisions. All but the smallest of these passageways have reinforcing cartilage in their walls. The primary bronchi, secondary bronchi, bronchioles, and terminal bronchioles.
Respiratory zone structures. respiratory bronchioles, alveolar ducts, alveolar sacs, alveoli or air sacs, site of gas exchange, alveoli only. We can view in this diagram the respiratory zone of the lungs, including terminal bronchiole, respiratory bronchioles, alveolar duct, alveolar sac, and alveoli. Inside the alveolar sac, we can locate the alveolar duct, alveolus, and alveolar pores. Terminal bronchiole, a thin-walled branches of bronchioles. Respiratory bronchioles, the smallest airways of the lungs. It delivers air to the exchange surface of the lungs, particularly in the alveoli. Alveolar ducts, a tiny ducts that connects respiratory bronchioles to alveolar sacs. In alveolar sacs, cells that exchange oxygen and carbon dioxide in the lungs. In the alveolar sac, we have alveolar duct that connects respiratory bronchioles to alveolar sacs. Alveolar pores connects neighboring air sacs. And alveolus, it is a singular form which refers to one alveoli. We can view in this diagram the scanning electron micrograph or SEM with 225 times magnification of human lung tissue, showing the final divisions of the respiratory tree. The terminal bronchiole, respiratory bronchioles, alveolar duct, and alveoli are the final divisions of the respiratory tree. Respiratory membrane, or the air-blood barrier. Thin squamous epithelial layer, or simple squamous epithelial layer, lines alveolar walls. So our alveolar walls contain simple squamous epithelial layer. Alveolar pores connect neighboring air sacs. Alveolar pores permit the airflow between each of the alveoli. Pulmonary capillaries cover external surfaces of alveoli. Pulmonary capillaries are tiny blood vessels surrounded on the alveoli. In the pulmonary capillaries, carbon dioxide is exchanged for oxygen from the alveoli. On one side of the membrane is air, particularly the alveolar walls, and the other side is blood flowing past. Happens particularly in the pulmonary capillaries. This is the detailed anatomy of respiratory membrane to fully understand its structure. We can see here the endothelial cell nucleus that controls the flow of blood into and out of the tissue. Alveolar pores connects neighbor air sacs that permits the airflow between each of the alveoli. Capillary, where the exchange of gas occurs. Macrophages, it clears the airspace of infectious, toxic, or allergic particles that have evaded the mechanical defense of the respiratory tract. Nucleus of squamous epithelial cells located in alveoli facilitate the gas exchange of the lungs and the exchange of nutrients and waste at blood capillaries. Respiratory membrane, where the alveolar and capillary walls meet. Squamous epithelial cell of alveolar wall allows the gas exchange. Surfactant secreting cell reduces the surface tension of air and lungs. Red blood cells in capillary, the red blood cells capture oxygen. And alveoli, gas-filled air spaces where the gas exchange occurs. For a much closer view of the respiratory membrane, again, we can see the endothelial cell nucleus. It controls the flow of blood into and out of the tissue. Alveolar pores connects neighboring air sacs. Capillary, where the exchange of gas occurs. Macrophage, it clears infectious or toxic particles of the respiratory tract. We have three respiratory membrane. First, the alveolar epithelium. Second, the fused basement membrane. And third, capillary endothelium. Alveolar epithelium consists of simple or thin squamous epithelium that facilitates the diffusion of oxygen and carbon dioxide from high concentration to low concentration. Fused basement membrane, where the alveolar epithelium walls and capillary endothelium walls meet. Capillary endothelium consists of simple squamous epithelium that forms the inner lining of the entire blood vascular system. Gas exchange. Gas crosses the respiratory membrane by diffusion, from high concentration to low concentration. Oxygen enters the blood for the regulation of cells in the body. Carbon dioxide enters the alveoli for it to exhale out of the lungs. Alveolar macrophages, or dust cells, add protection by picking up bacteria, carbon particles, and other debris. Surfactant, a lipid or fat molecule, coats gas-exposed alveolar surfaces. It reduces the surface tension of airs in the lungs. 4 events of respiration. First, the pulmonary ventilation, moving air in and out of the lungs, particularly the breathing. Ventilation stands for the movement of air between the environment and the lungs via inhalation and exhalation. Second is the external respiration, occurs in the lungs and alveoli. Gas exchange between the pulmonary blood in capillaries and alveoli. Oxygen is loaded into the blood. We exhale oxygen for us to have oxygenated blood and for the regulation of the body cells. Carbon dioxide is unloaded from the blood for us to exhale out the gas throughout the body. We can see here again the closer view of the respiratory membrane. Third is the respiratory gas transport. Transport of oxygen and carbon dioxide via the bloodstream. It occurs when oxygen diffuses across the alveoli. It enters the bloodstream and transported to the tissue and cells. Carbon dioxide diffuses out of the blood and into the alveoli to be exhaled out from the body. The fourth and last is the internal respiration, occurs in the bloodstream or arteries and veins. Gas exchange between blood and tissue cells in systematic capillaries. It happens when the oxygen diffuses from the blood. Oxygen travels into the cells and tissue of body. Carbon dioxide diffuses out of the tissue cells because carbon dioxide is not applicable in the body.
Respiratory system's mechanics of breathing or the pulmonary ventilation. Mechanics of breathing is a completely mechanical process that depends on volume changes in the thoracic cavity. So when we say thoracic cavity or the chest cavity, it is the second largest hollow space of the body. It is enclosed by the ribs, the vertebral column, and the sternum or breastbone, and is separated from the abdominal cavity. In the mechanics of breathing, the volume changes lead to pressure changes, which lead to the flow of gases to equalize pressure. Mechanics of breathing have two phases, which are the inspiration and the expiration. Inspiration is also called as inhalation, which is the process of taking air into the lungs, while the expiration or the exhalation is the process where the air is being expelled from the lungs. So one of the two phases of the mechanics of breathing is the inspiration. During the inspiration or inhalation, which is the process of taking the air into the lungs, the diaphragm and the external intercostal muscles contract, which means the diaphragm and the external intercostal muscles that originates on the inferior surfaces of the proximal parts of the ribs and insert on the superior and distal parts of the next lower rib will shrink or will decrease. Lungs, the size of the thoracic cavity will increase. So in the inspiration process, the upper tract, which are the thoracic cavity or the chest cavity, will increase. And external air is pulled into the lungs due to first, increase in intrapulmonary volume. Intrapulmonary means the pressure within the lungs. So external air is pulled into the lungs due to the increase of the volume of the pressure within the lungs. Second is due to decrease in gas pressure. Inspiration process creates a lower pressure within the lung than that of the atmosphere, causing air to be drawn into the lungs. So here is the visual presentation of the inspiration process. Here are the changes in anterior to posterior and superior to inferior dimensions. So as you can see, during the inspiration process, the ribs elevated as external intercostal muscles contract, and the diaphragm moves inferiorly or decreases during contraction. So here is the external intercostal muscles. And as you can see on the right side of the presentation, here is the changes in lateral dimensions, which means that in the full inspiration, the external intercostals will contract. So here is the figure of pressure relative to atmospheric pressure in the volume of breath during inspiration. So as you can see, during inspiration, there is no intrapulmonary pressure, or we can say there is no force exerted by gases within the alveoli. So in the volume of breath is 0.5. The second phase of mechanics of breathing is expiration, in which the air is leaving or expelled from the lungs. Expiration is largely passive, which depends on natural lung elasticity, which means that it's just a natural process that depends on the capacity of lungs' capability to expand. So as muscles relax, air is pushed out of the lungs due to first, decrease in intrapulmonary volume. So when the intrapulmonary volume or the pressure within the lungs decreases, this is when the air is pushed out of the lungs or exhalation. Second, it is due to increase in gas pressure. As the diaphragm and intercostal muscles relax, the lungs and thoracic tissues recoil, and the volume of the lungs decreases. This causes the pressure within the lungs to increase above that of the atmosphere, causing air to leave the lungs. Forced expiration can occur mostly by contracting internal muscle to depress the rib cage, which means forced expiration or the movement of air out of the lungs occur by shrinking the internal muscle to reduce the rib cage. Here is the visual presentation of expiration. Air flows out of the lungs. So here are the changes in anterior to posterior and superior to inferior dimensions. So during expiration, ribs depressed as external intercostals relaxed. So here are the external intercostal muscles. And during expiration, the diaphragm moves superiorly as it relaxes. So in changes in lateral dimensions, here is the expiration while the external intercostals relax. So there are two figures, which are the pressure relative to atmospheric pressure and volume of breath during expiration. So as you can see, in the pressure relative to atmospheric pressure, during expiration there is an intrapulmonary pressure, which means there is a force exerted by gases within the alveoli. And in the volume of breath, it's still 0.5 during the expiration process. So pressure difference in the thoracic cavity. So normal pressure within the pleural space is always negative, or intrapleural pressure. The pleural space is the tiny area between the two layers of the pleura, or the thin covering that protects and cushions the lungs. Between the lungs and chest cavity, the pleural space is normally filled with a small amount of fluid, and it is always negative. Differences in lung and pleural space pressures keep lungs from collapsing. The ones that are responsible for preventing the lungs to collapse are the differences in lung and the pleural pressure. Pleural pressure is the pressure in the pleural space. When this pressure is lower than the pressure of alveoli, they tend to expand. This prevents the elastic fibers and outside pressure from crushing the lungs, so it prevents the lungs from collapsing. So non-respiratory air or gas movements. Non-respiratory air movements can be caused by reflexes or voluntary actions. Examples of non-respiratory air movements are: first, cough and sneeze. It clears lung of debris or waste or remains. Next is crying, an emotionally induced mechanism or caused by the emotional behavior. Next is laughing, which is similar to crying, which is also induced by emotional behavior. Next is hiccup, which is a sudden inspiration. And lastly is yawn, a very deep inspiration.
Now let's talk about the respiratory volumes and capacities. Fun fact: did you know that normal breathing of a person moves 500 milliliters of air with each breath? Now going to the topic. Respiratory volumes are volumes of gas in the lungs at a given time during the respiratory cycle. And there are many factors that can affect the respiratory capacity of a person, and those are the person's size, sex, age, and physical condition. Under the respiratory volumes, there are 4 standard lung volumes that can be measured, and those are the tidal volume, also known as the respiratory volume, inspiratory reserve volume (IRV), which is the amount of air that can be taken forcibly over the tidal volume. It is usually around 3,100 milliliters. Next is the expiratory reserve volume (ERV), which is the amount of air that can be forcibly exhaled and is approximately 1,200 milliliters. Then we have the residual volume, which is the air remaining in lungs after expiration. It is about 1,200 milliliters. Next up, we have vital capacity, It is the total amount of exchangeable air. To be able to get this, we should get the sum of the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume. Next is the dead space volume. It is the air that remains in the conducting zone and never reaches the alveoli. It is only about 150 milliliters. Finally, we have the functional volume, which is the air that actually reaches the respiratory zone and is usually about 350 milliliters. Respiratory capacities are measured with a spirometer. In the next slide, you can see the total lung capacity measured in milliliters. The total is 6,000 milliliters and it is composed of the vital capacity, which is the inspiratory reserve volume, tidal volume, and the expiratory reserve volume, which makes up the 4,800 milliliters of the total lung capacity. Then the remaining 1,200 milliliters is the residual volume. Let's talk about the next topic, which is the external respiration. External respiration is also known as gas exchange, which is the transfer of oxygen and carbon dioxide through the bloodstream by the process of diffusion. External respiration has two parts, which is the loading of oxygen into the blood and unloading of carbon dioxide out of the blood. Let's go first to the loading of oxygen. The alveoli always have more oxygen than the blood. This oxygen moves by the process of diffusion towards area with lower concentration. The pulmonary capillary blood gains oxygen, which forms the oxyhemoglobin, also known as red blood cell. Then the unloading of carbon dioxide. Blood returning from tissues has higher concentrations of carbon dioxide than the air in the alveoli. Pulmonary capillary blood then gives up the carbon dioxide inside to be exhaled. After this process is done, blood leaving the lungs is oxygen rich and now carbon dioxide poor. In the next slide, you can see the visual representation of the external respiration in the lungs. You can see how oxygen is loaded into the blood and carbon dioxide being exhaled. Alveoli or the air sacs contain the oxygen needed, which is transferred to the process of diffusion towards the pulmonary capillary. When oxygen is transferred to the pulmonary capillary, it forms the oxyhemoglobin, or also called as the red blood cells. As oxygen is received to the pulmonary capillary, the carbon dioxide is now then exhaled towards the alveoli or the air sacs.
Now, let's discuss the gas transport in the blood. So how do oxygen transported into the blood? Most of the oxygen are loaded and attached to hemoglobin, and these two will form HbO2 or the oxyhemoglobin, while some of the oxygen are carried into the plasma. Now, as you can see in the picture, oxygen is loaded into the blood and carbon dioxide is unloaded. From our alveoli, we have our oxygen, and oxygen can jump in and bind into the hemoglobin, and this is how oxyhemoglobin is formed. Now, let's talk about how carbon dioxide is transported in the blood. So most carbon dioxide is transported in the plasma as bicarbonate ions. Small amount of carbon dioxide is carried inside the red blood cells and hemoglobin, but in different binding sites than the oxygen. So for the carbon dioxide to diffuse out of the blood into the alveoli, it must be released from its bicarbonate form. So the bicarbonate ions enter RBC, then combine with the hydrogen ions. Then these two will form carbonic acid. Then the carbonic acid split to form water and carbon dioxide. Then the carbon dioxide diffuses from blood into the alveoli. So this is how carbon dioxide is unloaded. The carbon dioxide that are dissolved in the plasma needs to get into the alveoli so that we can breathe that out. But what about the carbon dioxide that are transported as bicarbonate ions? So what happens here? The hydrogen ions will bind into the bicarbonate, then that will form carbonic acid. Then that will be associated and split into carbon dioxide and water, and the carbon dioxide will diffuse out in the alveoli. Now, this whole process happens in reverse when we get to the internal respiration. Internal respiration, it is the exchange of gases between blood and body cells. As I said earlier, it is an opposite reaction to what occurs in the lungs. In the previous one, oxygen is the one who is loaded into the blood and the carbon dioxide is the one that is diffuses out into the alveoli. In the internal respiration, the carbon dioxide diffuses out of the tissue to the blood and the oxygen is the one diffuses from the blood into the tissue. So we can see here that the carbon dioxide that is from the tissue cells can easily be transported in the blood plasma and directly dissolve into the plasma. Second thing is that the carbon dioxide can go in the plasma but it combined in water. What we get is carbonic acid. But as we all know, carbonic acid hates itself and split itself apart. Then what it forms is bicarbonate and hydrogen ions. As for the oxygen, we all know that oxygen is going to be in the red blood cells and we need to get it out to the tissue. So what we've got is oxygen bound to hemoglobin. But we need to do is disassociate the oxygen from the hemoglobin. And so we need to give up that hemoglobin and oxygen, and we now can do is get that oxygen out and send it out to the tissue. Now let's discuss about neural regulation of respiration. It is the activity of respiratory muscles is transmitted to and from the brain by phrenic and intercostal nerves. The phrenic and intercostal nerves are controlled by the respiratory center and issue rhythmic nerve impulses, causing synchronous contraction and diastolic activity of the diaphragm and intercostal muscles to produce respiratory movements. Neural centers that control rate and depth are located in the medulla and pons. The medulla is the primary respiratory control center. Its main function is to send signals to the muscles that control respiration to cause breathing to occur, while pons appears to smooth out respiratory rate. It is the other respiratory center and it is located underneath the medulla. Its main function is to control the rate or speed of involuntary respiration. So the respiratory rate or apnea is the number of breaths you take per minute. The normal respiration rate for an adult at rest is 12 to 15 respirations per minute. Hypernia, it is the increase of respiratory rate often due to extra oxygen need. Hypernia is your body's response to signal from your brain, blood vessels, and joints to adjust your breathing. Deeper breath provide an increase in oxygen intake. Hypernia can also be deliberately used as a calming technique or to help you improve your breathing if you have a lung-related diseases.
Respiratory volumes and capacities. There are three kinds, which is the inspiratory reserve volume, expiratory reserve volume, and residual volume. Inspiratory reserve volume has the amount of air that can be taken forcibly over the tidal volume, usually around 3,100 ml. IRV or inspiratory reserve volume is the reserve amount that can be exhaled beyond what is normal. Conversely, IRV is the additional amount of air that can be inhaled after a normal inhalation. So what is expiratory reserve volume? It has amount of air that can be forcibly exhaled, and approximately 1,200 ml. ERV is the additional amount of air that can be exhaled after a normal exhalation. And lastly, residual volume. Air remaining in lung after expiration and about 1,200 ml. Residual volume has the function to keep the alveoli open even after maximum expiration. It is utilized for continual gas exchange to occur between breaths. Respiratory disorder. Chronic observation pulmonary disease or COPD. exemplified by chronic bronchitis and emphysema. Major causes of death and disability in the United States. So what is chronic bronchitis and emphysema? The chronic bronchitis is the swelling and irritation of the bronchial tube, and the emphysema is a lung condition that causes shortness and of breath. The air sacs of lung are damaged. The features of this disease is the patients almost always have a history of smoking. So usually the disease starts with smoking and labored breathing becomes progressively severe. Coughing and frequent pulmonary infections are common. Features of this disease is also most victims are hypoxic, retain carbon dioxide, and have respiratory acidosis. Those infected will ultimately develop respiratory failure. So what is hypoxic? It is the condition in which the body or a region of the body is deprived of adequate oxygen supply at the tissue level. Respiratory disorder, or which is the chronic bronchitis. As what I've said earlier, chronic bronchitis is the swelling and irritation of the bronchial tubes. Mucosa of the lower respiratory passages become severely inflamed. The mucosa is the moist tissue that lines proteins parts of the inside of your body. Mucus production increases. Full mucus impairs ventilation and gas exchange. Risk of infections increases pneumonia, and pneumonia is common. Cold blue bloaters due to hypoxia and cyanosis. The blue bloaters is generalized term referring to a person who is blue and overweight. They usually present with shortness of breath and they have a chronic cough. Respiratory disorder, the emphysema. The emphysema is a lung condition that causes shortness of breath and the air sac of lungs are damaged. So it makes the alveoli enlarge as adjacent chambers break through. Chronic inflammation promotes lung fibrosis, airways collapse during expiration. Patients use a large amount of energy to exhale. Overinflations of the lungs lead to a permanently expanded barrel chest. Cyanosis occurs late and the disease suffers often called pink puffers. So what is fibrosis? It is the disease occur when the lung tissue become damaged. And the cyanosis is the bluish cast to the skin and mucous membrane, or called the pink puffers. As what you can see right now, it is the picture of the damaged lung because of the tobacco smoke and air pollution. So it may bring you to chronic bronchitis and emphysema, and the airway obstruction will be dropped.
Lung cancer. Lung cancer or lung carcinoma is the uncontrolled division of epithelial cells which line the respiratory tract. Its major cause is smoking tobacco product, and it has contributed to death of millions of people. It is also a well-known risk factor, and it is dose dependent, which means that smoking more cigarettes over a long period of time increases the risk. It has three common types. Squamous cell carcinoma, also called as epidermoid carcinoma, a type of non-small cell lung cancer that typically develops in one of the air passages or bronchi of the lungs. Adenocarcinoma, type of cancer that starts in mucous producing granular cells of your body. Small cell carcinoma is a type of malignant cancer that mostly arises within the lungs, strongly associated with smoking. Just like small cell, squamous cell carcinoma tends to be centrally located and has a strong association of smoking. It is also increased the risk of adenocarcinoma. Development aspects of respiratory system. In the first phase, lungs are filled with fluid and will not be inflated until 2 weeks after birth. Surfactant or surface active agent is secreted by alveolar cells that helps lower surface tension and may not be present until fetal development and premature babies. It usually appears 28 to 30 weeks of pregnancy. Homeostatic imbalance. It occurs when cells in the body experience a deficiency such as nutritional deficiencies that results to an unhealthy diet or when cells are exposed to influences such as aging and genetics. Infant respiratory distress syndrome usually happens when a baby's lungs are not fully developed and cannot provide enough oxygen that might cause difficulties in breathing. It usually affects premature babies, hyaline membrane disease or surfactant deficiency disease. It also known as newborn respiratory distress syndrome. Cystic fibrosis. It is a hereditary disease that might affect the lungs and digestive system. Body produces thick and sticky mucus that can clog the lungs and obstruct the pancreas. It can be life-threatening, and people with this tend to have a shorter than normal lifespan. Respiratory rate changes throughout life. Newborns, 40 to 80 respiration per minute. Infants, 30 respiration per minute. Ages 5, 25 respiration per minute. Adults, 12 to 18 respiration per minute, and rate often increases somewhat with old ages. Sudden infant death syndrome. It is a sudden and unexplained death of baby younger than 1 year old. Apparently, healthy infant stops breathing and dies during sleep. Some cases are thought to be a problem of neutral respiration control center. 1/3 of cases appears to be due to heart rhythm abnormalities. Recent research shows a genetic component. Next one is asthma. It is a chronic disease that involves the airways in the lungs. These airways are bronchial tubes, allows the air to come in and out. If you have asthma, your airways are always inflamed. It becomes even more swollen, and the muscle around the airways can tighten when something triggers your asthma. Allergy, non-allergic asthma, and occupational. In occupational, if you are stressed and anxiety sometimes makes you feel short of breath and may cause your asthma symptoms become worse. Coughing, especially at night or in the morning, that usually happens to me because I have asthma. Sneezing, a whistling sound when you breathe, shortness of breath, tightness, pain, or pressure in your chest, trouble in sleeping because of breathing problems, and usually happens to me also. Next one is aging effects. Respiratory muscle strength decreases with age and can impair effective cough. which is important airway clearance. The lung matures by age 20 to 25 years, and thereafter aging is associated with progressive decline in lung function. After about the age of 35, it is normal for your lung function to decline gradually as you age. This can make breathing slightly more difficult as you get older. Example of this is yung mga lola at lolo natin na medyo nahihirapan sila minsan maghinga. O kaya, ang dali nilang magulat, then hirapan kagad sila maghinga. And that's because of aging effect.